So military medicine in general is constantly evolving. Basically, it used to take our guys up to 2 weeks to come home from a conflict zone or being injured and training somewhere from another country to come back to the United States. It took them up to 2 weeks. Whereas now, with technology constantly evolving and medical, advancements and new things just constantly being researched, we can bring home a soldier within 24 to 48 hours of when they first sustained their injuries. So what that involves is basically the en route critical care evacuation system, which is there's different components of it. So it all started with the AE team, which is the aeromedical evacuation team. It evolved to the critical care air transport team, which is also known as CCAT, and then your tactical care evacuation team, which is also known as TACET. So, like I said, it started with AE. So basically it all started during World War II. So that's when, planes were a big thing. Everybody kept trying to say who's going to build the biggest and baddest planes. The cargo planes really started happening. And that's when, a lot of just millions of people were injured or killed during World War II. And so they couldn't get these patients out. We can't just keep them there. So they would use cargo planes like C-130s or something like that to move these patients out. And that took what they called air medical evacuation. And basically what that evolved into in 1994 from Dr. Joe Henigman and Lieutenant Colonel Carleton at the time, who retired as General Carleton, they really came up with this concept of the critical care air transport team. And what can we do what can we do for those really sick soldiers that, they can't be moved? AE, that's not what they were trained for. They were trained for maybe a patient who was shot but stable, or a patient who has maybe psychiatric issues or concussions or different things, of course, that happen from the war, but they're stable patients. So how do we move these critical patients, the patients that, that are just kind of stuck there to ultimately maybe succumb to their injuries because they can't get to the next point of care? So that's when the critical care air transport team was made, and that consists of one doctor, one nurse, and one respiratory therapist. And basically they are taught to become a mobile intensive care unit. So they're taught and they're trained at the University of Cincinnati to basically, they're taught to kind of step out their comfort zone, because in a hospital you have dozens of colleagues to choose from. I'm having a hard time with this patient. I don't know what to do next. What can you help me with? Tell me something I'm not thinking of. So you don't really have that capability when you're flying for 12 hours. You don't have another physician to talk to, so you really are taught to depend on your team and to step outside that box and to, kind of think and use one another as resources. So after the critical care air transport team, then you have your tactical care evacuation team. So your tactical care evacuation team is made up of one doctor, one nurse anesthetist, and one critical care nurse. So what their kind of role is resuscitative medicine. So let's say the combat medic on the ground did everything that they could. They tried to patch up what they could, but for some reason this patient still isn't stable and they need a blood transfusion or something that they just don't have the resources on the ground. So that's when a TACET team will come in, and their job is quick, resuscitate, get them to the hospital. These are life-threatening things. We need to get them stable to a hospital to go to surgery. So that's the TACET team, and they really started in 2011. And Those are kind of like I basically went over the different types of patients that they get, the different injuries, the team dynamics, and just kind of the evolving way that the Air Force has, gone about with moving patients. And with that, with the constant evolving and thinking forward, patients from World War II had less than a 20% chance to survive. Like, majority of them just succumbed to their injuries because they didn't have, like, tourniquets, things like that. It wasn't something that was really, they weren't the best tourniquets. They weren't, things, just simple things that we have that we think are simple now. They just didn't have those resources then. So just with all of that, and it brought down the survival rate, or it increased the survival rate up to 99%. So now your soldiers who are sick, this is of course if they don't immediately succumb to their injuries, they are able to get initial care and get to for a hospital for initial care and everything. Their chances of survival are up to 99%. And who really deserves it more than our patients? And this is basically kind of a mock-up of a general CCAT patient. So who knows what they'll come up with next? Who knows if, they'll do surgery or do something else like that at some point, because really, who deserves it more than our soldiers? So thank you. So this was about the en route critical care system in the Air Force. So I hope that you got something from it. Thank you.